Welcome to the Eye Surgeon. I'm Dr. Sam Barry.
I'm Dr. Koushik.
And this is Multifocal IOLs.
What are we talking about today?
Let's do multifocal lenses. Should we do that? Patient selection,
lenses.
patient guidance, all the ins and outs for patients, for surgeons, for, people that want to fall asleep at night listening to us.
I like it. I guess to think about multifocal lenses, what are patients coming in and they're like asking you about them already? They're like, hey, I want these multifocal lenses. Or is it 50-50? They don't know about it and then you're telling them about it?
There's definitely a subset of people that are like, hey, I've heard about these different types of IOLs, intraocular lenses that we can do, and what are the pros and cons of each? I don't know about you, but for me, that is actually easier. Some people might think, oh, that's like way too in the weeds and too specific and, red flags that a patient knows. No, I love that. I mean, that's like, we're just getting down to brass tacks. We're figuring out exactly like you're talking to me about my expertise and what patients, have enjoyed and don't enjoy and what would work for them based on their anatomy. So I find that much easier to start from that standpoint. And I'd imagine maybe in the Bay Area, like just because of the number of doctors and the access to care and the technology and stuff, maybe people come in with a little bit more of an idea. Is that the case for, I'm sure there's still a spectrum, but
yeah. I think you're right though. There's a spectrum, but there are a growing percentage of patients that are coming in pretty well informed. And I think the rise of, AI at our fingertips has really accelerated that, because a lot of patients will just come in with their phone in their hand and be like, hey, ChatGPT tells me this, and they'll even mention brands of lenses and things like that, or whatever, Google Gemini, Claude, all these different services. So they're coming in informed. I think I agree with you. I think that's really helpful when the patient already has information, they have questions, they want to dive into it. That's really helpful. I think the only issue I have is sometimes the information that they think they have is actually incorrect. And then you're spending a little bit more time trying to explain why that information is actually not true, or it may be true, but it's not true in the context of, for them and their eyes. And so, but overall, I think it's a net benefit.
I think you're exactly right. There's that primacy where like the first thing that you hear or the first way that you hear it is the way that you are most influenced by it and the way you remember it. So if they hear something that's correct adjacent, let's say, it's hard to backtrack from that, but I do think people eventually, if you talk to them and really tell them your opinion and your experience, at least for me, they tend to believe you and really take your word for it. But it does take a little bit extra time if they have the wrong idea from the start, just based on some research. Again, but with the best of intentions that they were trying to get the right information, which I prefer. I prefer people, try to educate themselves and come in like, with as much understanding as they can get on their own is great. But you're right. Sometimes it takes a little bit of effort to unwind those things that are not correct, or maybe apply to some people, but not other people. I mean, there's generalizations that you can come across through any kind of research, AI or whatever reading you're doing, that doesn't apply to each specific scenario. So
definitely. And I mean, I'm interested to hear your thoughts on this, because like when we're talking about multifocals or I'm coming into the room meeting a patient for the first time who's coming in for cataract surgery or lens replacement, oftentimes like what I personally like to do is just truly get an idea of what their visual goals are and expectations. And I'll just ask a simple question like, how has your vision been bothering you recently? And kind of get an idea of, is it really the near vision that's been an issue or a change? Is it the distance, intermediate and near? Like trying to figure out those goals, those problems, and then follow up with, well, what type of vision would you like to have even after surgery? And I would say still like, vast majority, 90% or greater, like, well, just fix everything, like give me everything. Yeah. And so that's usually a natural jumping off point to talk about these kind of multifocal lenses. But one thing that I'll say is, and you and I both have talked about this before, I mean, we talk about multifocal lenses as premium lenses, but really any lens could be a premium lens. And, oftentimes I'll hear from a patient where they're like, for example, I had a patient who's a race car driver. And so he was like, I just need excellent distance clarity. I don't want to compromise that. I have no issues with wearing readers. I have no issues with, having to use that for the menu at a restaurant or looking at my cell phone. But when I'm on the track, which is what I love to do, I want that. I don't want to sacrifice anything. So in that case and in that patient, we just elected to go for monofocal lenses and to give the best quality of vision. And he did great 20/20 vision and he got back out on the track very quickly after. But Yeah, trying to figure out patient expectations, desires, and then what things are really troubling them. That's kind of how I like to start. How about you?
I couldn't agree more. Could not agree more. The thing that's difficult is it's 2 parts medicine and 1 part psychology.
Yeah.
There's an ophthalmology and surgery side of things, and then there's like, does the patient know what they want? And it's, putting myself in their shoes. When I wore glasses, I was like, I just want to see perfectly at all distances. Is that too much to ask?
Yeah.
And like, that's what we all want. And for some people, for a 20-year-old that comes in for LASIK or EVO, that's a no-brainer. That's why they're so easy for consultations for us. Like, there's definitely technical aspects that we strive to do even better with every day, sizing or what, outcomes based. But by and large, we're able to deliver that full range of vision. When we're talking about like the 40, 50 plus crowd of patients, that's where it gets a little bit more nuanced in terms of, I like to kind of break it into range of vision and quality of vision. And those are those are both on a spectrum, and we can't have both be 100%. We can have range of vision be perfect and quality of vision, depending on where you're starting from. It could be a step up if you have a bad cataract, or if you're 20/20 uncorrected, but you just can't see up close. It's a whole different discussion. So again, it is something where patients can read and learn about it ahead of time, but where you're starting from is different for each person.
Yeah, I think you said it so well. I think the starting point is really a big determining factor in how happy a patient might be with a certain lens. And I think these are the conversations that are really nuanced, and that we really have to kind of like take a careful walkthrough with the patient to make sure that at the end of the day, I know you're an excellent surgeon. The surgery is going to be great. It's just, are they going to actually like the vision that they get? Yeah.
Yeah. And speaking of AI, I think that's somewhere that like an AI chatbot could do pretty well, actually, which is like having the patient goal discussion, a standardized way of figuring out where they're starting from, what goals they want. I think that's something that could be implemented and be very helpful, versus what we do now is kind of a informal questionnaire, or, just trying to really within the first couple minutes figure out where we're starting from and what the goals are. But that's something that a patient could do on their own time ahead of time and really guides kind of our whole visit.
Yeah. No, I think you're definitely right. But let's say now you got those goals and those, let's say the starting point for this patient is mild visual decrease at distance. So they're not 20/20 uncorrected. Maybe they're like 20/40. And then intermediate and near is also a problem. So they are wearing readers, or maybe sometimes they wear progressives. And so you've identified that problem, and they tell you they want everything fixed. They want the whole range of vision fixed. Where do you go from there? Like, what's kind of the next thing that you're going through in your mind as you kind of guide the patient through this conversation?
Yeah, I mean, that's a $1 million question. That's a great one. I think past medical ocular history is a good place to start, getting a good baseline of kind of where they're starting from, both from a ocular standpoint, but overall medical standpoint as well. Overall health of the eye, evaluate the whole thing from front to back. So that different imaging that we do, IOL masters, OCTs, eye traces, all these different things that we try to quantify, what are they seeing now? What's the quality of vision, and how can we improve upon that? Measuring everything from nearsightedness, farsightedness, astigmatism, higher level order aberrations, different metrics that we have of kind of quantifying their quality of vision. That's kind of where I'd go next. And then based on that, their age factors in, but presbyopia hits different people at different ages. And presbyopia is just that need for, some help with reading up close, anything arms length in. And I make the joke to patients, like, at some point your arms aren't long enough anymore to hold things far enough to see. And that's just because the lens of our eye just can't focus up close the way that it used to. And that concept, I mean, that's tough for people to understand. Number one, if they're early in the process, or if they're not even close to it yet, but they're pre-presbyopic, in their 40 to 50 range. It's just a discussion to have in terms of where they are on that spectrum of presbyopia. It's easy if somebody's 65 and, wears a 275 ad, but it's more nuanced when they're in the beginning stages and they're frustrated by that lack of near vision. So I'll throw it back to you, since I don't have the answer. What would you do in that scenario, and where would your head go in testing and workup wise?
Yeah, no, I think I would do the exact same thing. I mean, get an idea of their past medical history. I think things that, I'm always looking for as part of my decision-making process for using any type of lens is like, okay, do they have diabetes, or, uncontrolled hypertension, and all these kind of systemic medical conditions that can affect the eye. And then yeah, like you said, ocular history. So I'm always asking, even before I look at the patient's eyes, like, did you have LASIK in the past, or any injuries or trauma, and kind of be screening for those kind of things even before I start looking at the eye, or even sometimes before I even pull up the scans to kind of show the patient, like, this is what I'm looking at, and I'll talk to you about it in real time. But those kind of things will help kind of guide my judgment uh, toward or away from a multifocal lens. Like you said too, even looking at those imaging, I'll usually have like a Pentacam obtained for both eyes, an IOL master for both eyes, eye trace, and then OCT macula. And those are kind of my typical go-to imaging software. And I will kind of walk through all of those with the patient and figure out what direction we're headed towards. And things that I'm looking for are things that you just mentioned too. Like, I'll look at the Pentacam and I'll start trying to figure out higher order aberrations, But even before there, just simple stuff like astigmatism and how much is it, or
Hmm.
dry eyes, and is this even a good scan, and things like that. All of that is really important, and I think the patient gets it as I start explaining from that point on. Like, so for example, the patient has myopic LASIK. Right off the bat, I'm showing the Pentacam and I'm saying, like, do you see how the center of this cornea is flattened? Do you see how the periphery is different than the center? This changes the way light is entering the eye. And then I put in a multifocal lens into your eye, it's going to change some more. So let's kind of talk about, without going too into the weeds, let's talk a little bit about the physics of that, or the optics of that, and how that might affect your vision. Because glare, halos, all these kind of things are possibilities with multifocal lenses, and making sure that the patient is aware of that, and also aware how likely that is for them given their eye anatomy, is really important.
I couldn't agree more. Yeah, absolutely. And you hit on a few points there, especially kind of past ocular surgery history being really important in terms of IOLs that we select. And we can get into the weeds of like what our preferences are for certain IOLs for certain history. But it's good for patients to know that both now and, when they're making our younger patients that are making those decisions. I talk about that sometimes, and it's hard to quantify or to have patients say, think ahead 30 years, 40 years when you're going to need cataract surgery. I mean, it's a good thing to think about, but I also think about how much technology is probably going to change between now and 40 years from now when they're going to have that cataract surgery. But yeah, when I talk about LASIK versus EVO, I say, hey, there's certain lenses right now that with cataract surgery tend to kind of avoid in people that have had a high amount of LASIK ablation. Smaller amounts that, not so much, but the more ablation or the more prescription that they've had corrected, the more I think it tends to affect their vision. I don't know if you feel the same way, but I think, the more flattening or the more difference between the central and peripheral cornea, the more they're prone to having those issues. Also people dependent, of course, but that's not something you can especially control. So,
yeah, no, I agree with you completely. And I mean, talking about that point, something that we look at often as surgeons, like we mentioned, higher order aberration, spherical aberration is a big thing that we're looking at. And spherical aberration changes depending on the size of the diameter of the people that you're like looking at. So for kind of most things that I think we're talking about, I think we're typically defining that as like a 6 millimeter optical zone. So looking at that 6 millimeter in a patient who's had, let's say, myopic LASIK or nearsighted LASIK, that spherical aberration has now changed, and it is going to change depending on how much was done, as you mentioned. And so it really, in layman's terms, probably the easiest way I could say is how much of the difference in the center of the cornea was flattened, and then the relative periphery of the cornea, which is steeper, how does that change the way the light rays are now entering your eyes? Because the steep area, I'll tell patients when I'm looking at these kind of scans, the steep area is bending light more, and it's going to come in front. Those rays are going to be in front of the center rays, which are going to actually go behind because they're not bent as powerfully by that cornea. And that difference, or that kind of change of where the light rays are, that's essentially spherical aberration. And that is really important when you put a multifocal lens into a patient, because you're bending light again multiple times. And this is a big concept with like changing contrast, something that I definitely spend time talking about with patients, because that's so important, right? In dim lighting conditions, things can be worse. If you're very visually inclined with graphics, art, all of that kind of stuff, you might find it to be more problematic after a multifocal lens. So anyways, I'm kind of going off on a tangent here, but I agree with you. I think looking at the amount of ablation is important when you're deciding these kind of IOLs.
Yeah, no, you weren't going off on tangent at all. That was like very applicable to so many people because so many people have had LASIK. I mean, millions of people have had LASIK, and the vast majority of that is myopic, or nearsighted correction. You could be looking at my eyes, could be looking at my eyes in a few years, and that's what I had done. Whereas for you, your eyes are pristine, you just remove the EVO, you're back where you started. So
Bam, reversibility.
Yeah, I talk about that every day when we see our EVO consults, reversibility, the lack of dry eye outcomes with EVO. I really like that. At the same time, LASIK has really great outcomes, and there are some people that are much better LASIK candidates than EVO candidates. So it's not like it's fully replaced it, but it's a nice addition to what we can offer refractively.
Yeah, no, I totally agree, especially like now that we have a Wavelight Plus, and it looks like the data from that is even better at getting these patients to even better than 20/20 vision. I think laser vision correction is still fantastic, and just being sure that you're identifying patients that are great LASIK candidates is really important.
Yeah, we should do an episode on, I feel like, just LASIK. That would be really helpful because there's so much misinformation and disinformation about LASIK out there. Because we were just at ASCRS, and there was a joint like military and civilian refractive surgeon kind of conference. And it was great to go over, they went over PROWL and PROWL 2, which are like the prospective or patient reported outcomes with LASIK. And I tell people that all the time, it's like the number one most studied medical procedure is LASIK because you're starting with healthy eyes and you have to be overwhelmingly positive outcomes, and people talk about dry eye halo glares. Those are kind of the main things that people talk about with LASIK. When you look at PROWL, they asked before and after LASIK, those outcomes, the patient reported outcomes. How much do you have glare, dry eye halos? And there were a lot of people that had it post-op, but there were even more people that had it pre-op. It was a much bigger percentage of people. It actually, LASIK reduces all of those negative outcomes. There's less dry eye, which I can report for myself too. I had more dry eye with contacts than I do now. I remember the first week after LASIK having some halos and starbursts. And then after I healed up that week, now compared to the way it was pre-op, things are better now, So you're exactly right. Like what you're able to do with the laser and with our, whether it's Wavelight Plus or Wavefront optimized or guided LASIK, you can take these really, really big data sets and, just have great outcomes with post-op vision, better than you can do with, glasses that are made in an hour or contacts that are stock. You know what I mean? Like it's very custom to be able to do the things that we do with LASIK. So it is super cool. It's not dead.
No, not by any means. And you're right. We should do a whole episode on that because there's a lot of misinformation. And I think also too, sometimes patients think, well, it's been out for a really long time, so is it really like the latest and greatest? And I think that's like a misnomer too, because it's like, hey, just because it's been out for a really long time, I mean, that's great. I mean, we just have more and more data. So, that's improving outcomes. Yeah, I don't think in today's day and age where everyone's like, I want the latest and greatest, we need to kind of educate patients on that as well.
Yeah. I told somebody today I had LASIK 12 years ago, and I was like, man, I'm old. Old man Sam. 12 years ago.
Oh, man. No, you're still super young.
And then I told him I'm
Sam.
Benjamin Button. I'm aging backwards.
Yeah.
So,
yeah. You're going to be doing cataract surgery in the body of a 2-year-old.
Yes, very soon.
Yeah.
All right. So we talked about imaging, Pentacam, IOL Master, eye trace, that sort of thing. What would be next in terms of your exam or your consultation when we're talking about cataract and refractive lens surgery?
Yeah. So at this point, we've already got the imaging talked about with the patients. We've already kind of got expectations and desires and, all that, and past medical and ocular history. So now I'm just telling the patient, let me take a actual look at your eyes with the slit lamp and let me identify anything else that could be relevant to obviously the discussion of what type of lens to put into your eye. And this is actually, I think, the part where a lot of patients seem surprised almost. They're like, well, I mean, you got all these scans and like all of that. Like, why do you even need to look at my eye? And it's just funny to me at that point because I'm like, there's a lot that we are getting just from looking at your eye. I trust that, just as much, if not more, than just looking at a scan, right? So we'll do the slit lamp exam. Obviously, there are different ways to do that. I think different surgeons have different preferences on, whether they're going to dilate the eyes that day, dilate the eyes a separate day, or, I've even heard sometimes surgeons won't dilate the eye routinely if they don't
It's this
find
guy.
a
It's
reason
me.
to.
It's me.
Yeah, exactly. So
Especially if patients have had a recent dilated exam with their eye doctor. Like,
yeah,
yeah, you've had that recently. They even sometimes will come with a sent over wide field the fundus
mhm,
photo. I'm like, this is more than adequate. This is fantastic. But
yeah,
if there's an indication to dilate, I will. But a majority of people, I probably won't unless there's some indication for it.
exactly. And so I think that's why this is like so helpful, is like just hearing kind of that there's no right way to do it. It's just what's your preferred methodology. But yeah, looking at the slit lamp exam is helpful because sometimes you'll find things like on the cornea, like you'll actually find out, wow, this patient actually has a lot of dry eye, and we got to first optimize that because there's no point in putting this multifocal lens in the eye with this kind of dry eye. Or corneal scarring, or other kind of conditions like fuchs endothelial corneal dystrophy that you might not pick up on any of the scans initially. And then kind of just moving forward, things in the anterior chamber, inflammation, things on the iris, like if there's transillumination defects, if and talking about dilation too. I mean, if you do end up dilating, you might find, okay, this person just doesn't dilate really well, and it has nothing really to do with whether I want to put a multifocal in or not, but it could help in terms of planning the surgery itself. And then looking at the lens itself and stability of the lens. I mean, one simple trick that I learned in residency was just gently tap the slit lamp, table as you're examining, just to see if there's any kind of loose zonules, or the lens kind of wants to, or what we call phacodonesis, any kind of like movement. I'll still do that and kind of just see and just make sure, because talking about multifocal lens, centration is so important, and you want to make sure that when you put it in the eye, it's not going to decenter or have the patient looking through one of the rings. So that's important. And then finally, of course, looking at the vitreous floaters are actually like a pretty big thing, which I factor in. I mean, not crazy heavily, but I talk about it with patients, and sometimes I'll have patients that actually do great with a multifocal lens, but some of those floaters are actually detracting from the quality. And then, of course, the optic nerve and retina. But essentially, slit lamp gives you so much information, and that truly is I think, in my opinion, one of the final steps of kind of figuring out whether this patient should get a multifocal lens or not.
I couldn't agree more. I mean, it's a combination. It's a slit lamp, but it's also your own eyes. It's you, it's your eyes
Yeah.
and what you've seen in thousands of patients before. And there's really no replacing that. I mean, I think there's coming a time where imaging is so good that we can get almost everything we need from it. But there is still, at least for me, I think there's still a role for looking at the slit lamp. I think a lot of people, probably it's the same. It doesn't change anything. But for some people, there are clinically significant findings that change the plan based on the slit lamp exam.
Yeah. And something else that I'm going to say next, which may be like a controversial take, and I'm like interested to hear kind of what you say.
I'm ready for that's what makes this podcast so great. Hot topics.
I'll say, like, when I was first kind of getting really interested in refractive surgery, a lot of the discussion was about understanding some of these optical principles like angle kappa. Of course, like we talked about, spherical aberration, coma, things like that, these higher order aberrations. And then even having kind of like cutoffs that you're like looking at, numerical cutoffs where you say like, hey, based on this scan and based on these numbers, probably not a great candidate for a multifocal lens. And that, I think, when I was like first starting out, that almost felt like, I should say, like gospel. Like it almost felt like, hey, this is like, if they don't meet these things, then no, not happening. And I'll say my thought process on that has evolved a little bit, where I think I still do have general guidelines, and I still do look at certain numbers as, hey, maybe I should be a little bit more cautious with using a multifocal in this eye. But I would say it's just now one part of the bigger picture, like we talked about. And so if the patient's personality is very kind of relaxed, and they're like, don't think I'm going to be bothered by halo and glare, or if I had halo and glare, who cares? For me, not having the glasses is the most important thing. And then on top of it, I see that maybe for example, like the spherical aberration is just a little bit higher than I would like. I mean, I can kind of at least make that decision call based on the whole picture versus saying, okay, it's a little bit higher, I'm not doing it. Like that type of clear cut. I don't know what are your thoughts on that? Do you have kind of like, hey, these are numbers and we're not going past a certain number, or you take those numbers into account and they influence whether or not you make that call for the patient, but it's just a part of the whole decision?
I completely agree with you. Couldn't agree more. I could not agree more. I don't have a cutoff. There's no number where I'm like, I'm not going to do it for this. It depends on the patient. And I think 2 points. One, I think it emphasizes how you have to be okay with exchanging lenses if you're doing multifocals.
Yes.
You have to be. I go talk with our, local eye doctors and I tell them, hey, if somebody's not happy, that's perfectly fine. I want them to come back and see me and we can make it right. We'll exchange the lens. We'll do whatever. It's no extra cost. That's just the cost of providing the service to people. That's really what it is. If somebody pays for that outcome, that's what I want to deliver. And there's times where we're like, hey, this is the best we can do and have that discussion. But there's also times where we're like, hey, you're not happy with it? We'll exchange it. No problem. So having that in your skill set is important. And I'm not saying it's special to us. It's just, you have to be willing. It is nice to have an OBS where you have your own OR time and you can do it easily. I mean, that access definitely helps, but the actual skill of doing it, is probably less than cataract surgery. It's more about just how you do it, the skills and the kind of technical instruments that you need for that. So that's point one. And then point two, I have a hot take as well. But okay. Go ahead first. You go ahead.
Well, no, I was just going to say, I think that's so true. Is like anyone who's doing a high volume of refractive surgery and using these different multifocal lenses, you do have to be very comfortable with taking these lenses out of the eye and being able to kind of tell the patient that, hey, that may be a possibility. And that's something I do tell every patient that I do a multifocal lens on is, hey, I think you're going to be happy with this. Otherwise, I wouldn't recommend it for you. But if you're having kind of like issues or you feel like, the halo is different than how we talked about or how you pictured it, and it's a deal breaker or something like that, then come back, let's talk about it, and let's talk about removing it or exchanging it for a different lens. And so I'm curious to hear your hot take, but I just thought that is a really good point, and that's something that the surgeon should be aware of when they're putting a multifocal lens in, but then the patient should be aware of as well. Like, hey, this is a process. This is a journey. It's not like, you have the lens in and we're done. It's like, hey, do you like it? Do you want to have it exchanged? So on and so forth.
Yeah, absolutely. And for me, I don't know about you, it kind of comes in waves. Like I went months and months without exchanging a lens. And then this past 2 weeks, I've exchanged a lens a week, like 2 lenses, So it just comes in waves. And I mean, if you do thousands of cataract surgeries and thousands of these cases, you're going to have patients that are unhappy, whether that's refractively or just hasn't met their expectations. And that's perfectly fine. You just have to remember that you're on the same team. You're trying to reach the same goal, For some patients, it's exchanging a lens. For other patients, we have somebody recently we did LASIK for that was like -3/4, -75, And for other people, they'd be like, this is a great outcome. I can see everything I want to see. I'm 20/25 for like the whole range,
Mm-hmm.
And for him, it was like, this is horrendous. You got to fix this. Yeah, I get that. I'd probably be the same. I'd be me, I'd be like, yeah, that's not adequate. That outcome of 20/25 is not what we're aiming for. But ultimately, we're aiming for 20 happy. That's what we're going for.
Yeah.
Yeah. My hot take, just the hot take that I have is you were talking about lens centration. My hot take is the capsulorhexis, like the opening that we make for cataract surgery, has no impact on lens centration. And I don't think multifocal lens centration is as important as we make it out to be, as important as we think it is. I think we could essentially do cataract surgery, put the lens in, and that lens is going to sit where it wants to sit. I don't think me tapping on it at the end of surgery is going to significantly alter where it sits for the remainder of this patient's life. But I could be wrong about that, but that's my hot take is I remove the viscoelastic, I try to get it set where it's the Purkinje images are centered up. But I also think in the back of my head, if I didn't do any of that, it would end up where it ends up because the haptics have a certain elasticity. The capsular bag is a certain size. What are your takes on that?
No. Well, the first thing I would say is I agree
I'm dead
with
wrong.
you.
I know.
No, I was going to say I agree with you that it's a hot take. I do agree with that. I also agree with the fact that, I do spend, and you could talk to my scrub techs. They're probably like, Dr. Koushik, because like after I put the lens like in the bag and just like I'm centering the Purkinje images, I'll literally sit there and then just like keep staring at it, right? Like almost like making a wish for a genie to, please keep that exactly where I put it.
Yeah.
But you're right. I mean, I do agree with you. Like, just because you put it there and you stared at it for, 20 seconds, it doesn't mean it's going to stay there. It doesn't mean that positioning is not going to change or
You know what my
Like you
proof
said,
for this is? Because it's studied. And that maybe not.
yeah,
I haven't found any studies on that, but it's toric IOL rotation. People very purposefully put torics at a certain axis, and they
yes,
certainly rotate. You know,
yeah,
then not frequently, but they do. So who's to say? I mean, rotation's a big thing. We're just talking about shifting a few microns almost from side to side.
yeah,
So
yeah. No, I think you're, yeah,
and there's so many. Not to get lost in the weeds. There's so many parts of this optical phenomenon that we're not measuring. Tilt, IOL tilt.
yes,
And there are more and more spectral domain OCT things or, SSOCT things that are coming out about how to quantify that. I think at the end of the day, we have to use that data, try our best. And then if somebody's unhappy, we address that. You go in with the best of intentions, the best plan, and then you just deal with the outcomes. And the outcomes, luckily for us, are so overwhelmingly positive with the technology we have that we're splitting hairs here, but we want it to be 100% perfect. That's really what everybody's striving for. And if we're at 98%, we want to get that last 2% just perfectly.
Yeah, no, I mean, that's totally true. I think all of us are just like very driven people, and 98% is never going to cut it. Like you're always going to say, I want it to be better, and this should be better. How do we make it better? And so that's totally right. And I think the other thing I'll mention with your statement, which I think is a good thing, is for all the kind of younger surgeons, and I still include us in this group. I mean, we're still young. At least I tell
had
myself
LASIK
that
more than a decade ago, but yeah.
But I guess what I would say there is maybe have some comfort in knowing that you do your best and you do all these things and you take into account, just like you said, the Purkinje image, the centration, making a perfect capsular rhexis, making sure that there's a good anterior capsule overlap to the optic, all of that. Like you want to still do that because I think that's just good practice. But yeah, I mean, if at the end of the day, the eye is going to do what the eye is going to do, the lens is going to settle the way it's going to settle. And then just being comfortable with that fact where it's like, hey, I've done like the best that I can do. And if things don't turn out visually the way the patient wants, that's not a reflection kind of on me, but also being able to say like, okay, well, now where do we go from here? Like, how do I then help the patient from this point kind of moving forward? And that might be a lens exchange. That might be kind of going into a different lens territory. But I think that's helpful for new surgeons because oftentimes, like we said, these surgeons are so driven and it's like you can start beating yourself up pretty quickly unless you kind of take a moment and realize some things are truly out of the control of your hands.
I couldn't agree more. Well said. Well said. The last thing we kind of had on our agenda was patient expectations, personality, and that kind of ties into what you're just saying in terms of you really make the best plan based on their anatomy, based on their pre-op expectations, but post-operatively, you have to be able to say, hey, we're on this journey together, we're on this same team. We're trying to reach that same goal of getting you 20 happy at that whole range of vision that you're looking for. And if we're not there, then we discuss the ways to get there. But briefly, before we get to that, since that's kind of the end, I would say is like the end of the journey, how to, those outliers that, I would say probably 98%. Would you say it's kind of accurate in terms of like getting on that first attempt, getting somebody where they want to be? I'd say even less than that in terms of like IOL exchanges or touch-ups, less than 2% probably across the board. But I think that has a huge testament to do with technology and lenses that we have available today. I don't know if we want to or you want to name names in terms of technology that we like to use, but I think it's helpful. I love other surgeons that make videos and talk about their experience with lenses. We all have our preferences for certain ones, but I think it's helpful just to talk about that in terms of right now. It's 2026, what the best lenses we feel like are and what we do. Obviously, again, with the caveat that it varies from person to person and no two eyes are going to be the exact same. Even family members or husband and wife that come in have totally different preoperative measurements and expectations and personality. But we like to group lenses in terms of function, what they do. If you put it on a desktop, a bench top, and you measure how light travels through it, we kind of measure it in terms of trifocal or multifocal, extended depth of focus or kind of like range of vision lenses, and then monofocal, basically. I mean, toric, along that whole spectrum, toric just means correcting astigmatism, which is a no-brainer. You have to do that if you're doing multifocals or extended depth of focus lenses. But yeah, I'll put you on the hot seat first. Okay. Unless you want me to go. I'll go first. My favorite phakic IOL is EVO ICL. So
yes, that Good job. You really kind of put yourself out on a ledge there.
I really did. The only one available by the
yeah,
FDA in the US.
yeah. That I mean, I think you're brave for saying that, and I want to commend you. But
Thank you.
for
And since it's literally inside your eye right now, you might be a fan of EVO ICL as well.
yeah, I would agree with you. Number one phakic lens, in my opinion, and in my eyes. So
Yeah.
but no, I mean to answer your question, at least with the intraocular lenses after like a lens replacement or cataract surgery, I think well, first I'll say no financial disclosures. I don't have any partnership with any of these companies for these lenses, so I think I can hopefully give an unbiased approach to that. But let's talk about multifocals first, since that's the topic of this podcast. I mean, I do like and have had a lot of success with PanOptix and also with Odyssey. So one is with Alcon, that's the PanOptix, and then Johnson and Johnson makes the Odyssey. And for another lens, which I have less experience with, but I've heard great things and I want to start using it more, is the Envy kind of multifocal lens. But that's kind of where I am right now in terms of multifocals. I would say Odyssey, PanOptix, kind of depending on what I think with that patient. But I would like to start implanting more Envy, just due to the fact that I've heard so many great things from other surgeons and from happy patients. And one question, and this might be tricky because I don't have an answer to this question, by the way. I think I need to sit down and look at all my data between the different lenses to figure it out. But after I hear like what your preferred multifocals are, do you feel like in your hands at least, because this is surgeon specific, like there's one type that has a lower rate of exchange?
That's such a great question. I think so. PanOptix and PanOptix Pro and Odyssey, I have had great success with, and the rate of exchanging, I would say, is about the same, maybe a little bit lower for Odyssey and a little bit just slightly higher for PanOptix and PanOptix Pro. But we're talking about, statistically insignificant, a couple patients here or there maybe. And Envy is what I've completely switched over to, actually, over the last 6 months or so.
Yeah.
And there's always that bias of the lens hasn't been around for as long as the rest of them, right?
Mm-hmm.
Invista Envy's been around for like a year, but I love the Invista platform and the monofocal. It's been great for years. And the trifocal or multifocal, I think, performs really well. It gives great clarity at distance, great intermediate, great near. Mm-hmm. And my experience, and this is just, again, my one surgeon experience, is PanOptix has great near, really good near, but distance might be a little bit less. And then Odyssey is the reverse. Odyssey, a little bit more distance, a little bit less near. Again, totally dependent as well.
Yeah.
Like if somebody ends up refractively a little bit myopic, it's going to totally change, right? So the only way to test this is really rigorously to correct everyone for planosphere and then test the range of vision. So this is really just based on real world outcomes, just based on seeing people, So it may not reflect exactly what the benchtop research says, but that's just been my experience. And again, I think Envy in like 2 years, if that's still what we're doing for everybody, would be great to know what that IOL exchange rate is. Right now, it's super low because I tend to not exchange before 2 or 3 months post-op anyway, to give people a chance to adapt. But yeah, I don't know. That's my 2 cents. What do you think?
No, I love it. I think that's fantastic. And I would find a very similar kind of feeling on my end. I mean, with my Odyssey patients, I would say that intermediate to near is what they do struggle a little bit more with compared to something like the PanOptix. And then I haven't done Envy enough to make a conclusion or have any information on that. So I can't really speak to Envy, but hopefully in a few months, I'll be able to give you more information on my end for that. But the other thing I was going to say is, because you made a good point, obviously the only way to really know is if everyone hit plano, and that was correct. And then you could really kind of get that data. But when you're implanting these lenses, do you ever kind of do a kind of like mixed refractive target or are you shooting plano in both eyes? Yeah.
Plano, both eyes. And I know that's a hot take too. Some people are really like, oh, I aim first minus and the non-dominant. To me, it's too many factors. It's like, it's one more thing we can't control if we're just kind of willy-nilly aiming for. And again, that's not to say it's the wrong thing to do. Just in my hands, it adds another variable that's hard to control.
Sure.
So
yeah. No, I think that's a really smart point is you're trying to control variables. And if you're trying to figure out like how is this lens actually working in all these patients' eyes, trying to limit variables is a good way to know that. And so, yeah, I think that makes a lot of sense. Moving on to extended depth of focus, I'll say, honestly, I mean, my go-to EDOF is Vivity. I actually am a big Vivity fanboy.
I love that we can have a podcast where we completely butt heads. I love
Yeah. That's good because we're normally so much in agreement, right?
I know, yeah. Nobody wants to hear that, just agreeing with each other.
So tell me, now your turn.
I don't really do any EDOF lenses, EDOF. Okay. I know that's in itself kind of a hot take, but I'll tell you why. I think monofocal lenses have gotten really, really good, and monofocal lenses give some depth of field. Not like anywhere close to what you want to get with like Vivity or Symphony or some lens like that, right? But if somebody prioritizes quality of vision, I want to deliver quality of vision. If they prioritize a range of vision, I want to give them range of vision. And I feel like that kind of is in that messy middle of like giving them a little bit of both, but neither one perfectly. But I also know that's not true for everybody. Some people are thrilled with them. They love their distance. They love their intermediate and near with EDOF lenses. So maybe it's just, again, me trying to control too many variables. But if I simplify the number of lenses that we do, then we can also sort of standardize our protocols and outcomes. So,
yeah. I mean, that's a good point. And I'll bring up like a little mini case here, and I'm interested to hear your thought because I'm going to use an EDOF Vivity lens on a patient coming up. She's a clinician, a lab scientist. So she's like doing bench research. She does a bunch of microscope use. And of course, obviously with the microscope, you can adjust the power. And so that's there. But she said independent of work, she would still like to be able to, look at her computer screen without needing reading glasses for the computer screen. And then if she had to use like readers for a cell phone or a book or something like that, she's totally fine with that. And she does prioritize like good quality vision. She doesn't really want to do a bunch of like, she's not interested in multifocals. She's like, I don't really want to deal with any kind of loss of contrast. I don't want to deal with more halos and glares. And so we talked about this in detail, and I kind of said, okay, for your dominant eye, I'm going to do a monofocal lens, set for plano. And then for your non-dominant eye, I'm going to pretty much set it for plano as well, but I'll use the Vivity lens in the non-dominant eye. Because that way, I think when you're at work and you're using the microscope, you'll be just fine. You can control your oculars there. And then when you're not using the microscope and you're not at work and you're just kind of looking at the computer, the Vivity will definitely help you with that versus if I just did kind of two monofocals for distance. And so hopefully she's like ecstatic with it, but I'm curious, like, I mean, in that type of scenario, do you think that's reasonable, or would you be like, even in there, I would probably just do a monofocal in the other eye? It's still going to give a lot of range, and maybe I'll offset it a little. Like, yeah,
and it helps really to have a patient conversation, like a actual presentation to talk about, lens selection going that way. There's tornado sirens going off here, so if I pass away, I was doing what I loved.
Stay safe.
Just know that.
Yeah.
Just know that the only thing that I would like to be doing more is doing cataract surgery right now, or LASIK, or EVO, and then I'd be real happy. But we talked about it today because we had tornado sirens going off earlier, and it was a clinic day. But we were like, we would just cancel cases and reschedule people because it's elective surgery after all. You're not going to be like, oh yeah, let's in the middle of this tornado siren start a new case. We'd wrap up a case and then be like, all right, we're going to pause for a while.
Yeah,
but yeah. So to your point, I guess you were talking, I thought I wasn't totally honest and truthful in that I forgot that we do light adjustable lens, which is basically an extended depth of focus lens. So I was completely wrong. We have that patient, because we were talking about it, that patient, I was like, that's what I would do. I would do light adjustable lens for them because that's the right fit for them. And sometimes it's just about finding that right fit for the patient, right?
Okay,
that patient prioritize. Oh, good.
I'm going to be a stickler here and say the maximal pupil dilation is 5.5 millimeter, and they also don't want to come back for multiple visits. No, I just want to put you on the spot.
Dilation doesn't matter to me. I mean, yes, it matters because you want to be able to adjust it. But at the same time, I think the amount of adjustment you can get done with smaller pupillary dilation, I've done that lots of times. So
sure, yeah,
I don't necessarily factor that in. I'll put a Malugan in just to do, adjustments.
Yeah, radical.
Yeah. Just leave it in for the whole until the adjustments
until
are done.
they're done.
Yeah.
That's a hot take.
that would be a really hot take. Yeah. But if they don't want to come back for those visits, that is a different discussion for sure. And there are people that come from a while away, hours away, or, are only in town for just the surgery or something, that we couldn't do that for. So yeah, you're exactly right. In that case, I'd probably do a monofocal lens, but I wouldn't blink at somebody doing a Vivity or a, Symphony in that scenario. Yeah.
Mm-hmm. Got it. Yeah.
Yep.
And then I guess the final category here is just like monofocal lenses, since we're talking about that. Like, what are your go-tos for that? And obviously, as we know, very patient specific and all that, but
yeah.
Do you have stuff that you like?
Yeah. Gosh, when it comes to monofocals now, what we do, I guess you should just let what you do speak for itself. We do a lot of Johnson & Johnson because the preloaded lenses are fantastic. They deliver great outcomes. They're very consistent. But for years, I was also using the Invista monofocal MX60E or EE or whatever name you want to call it. But it's a great lens. I think there are nuances, like you said, about spherical aberration and design of the monofocal. But by and large, they're all pretty equivalent. Just little surgeon-specific things that you might like or reasons to consider one over another for a specific patient. But yeah, that's the lion's share of what we do is preloaded Johnson & Johnson Technis lenses.
Yeah.
How about you?
Yeah, no, I agree with you totally. I love Johnson & Johnson. Preloaded is so easy.
Yeah, except for the haptics that just never disengage and it unfolds a little slowly. Yes. This is just my neuroticism coming out.
Yeah. No, you're 100% right. I sit there too and I'm just staring at it, and then I'm finally like, okay, let me just separate them myself. And yeah, but
yeah, I hold my second instrument in my hand now. It's changed how I hold things. I hold it until I'm done with the case.
With that. Yeah.
Yeah.
You're just like, this will not leave my hand.
Won't leave my hand. Yep. Otherwise, I have to ask for it back, and that makes me angry. It's just
but I mean,
angry, like muttering under my breath, just to myself. Yeah, and saying,
like, what is Dr. Barry saying?
He's saying something about kissing haptics. This makes no sense. What's going on here? Yeah.
He's talking in tongues.
Yeah. The Invista lens, though, I do find it unfolds at perfect rate. Goldilocks. Not too fast, not too slow.
Yeah.
It's great.
That's a great lens. Yeah. I love using that lens as well. But I mean, to your point, really, it's like when it comes to monofocals, there's so many great options, and really it becomes like splitting hairs, I think. And you're right. Some surgeons will prefer one over the other, but I think if you are a patient that is listening to this, just know there's never been a better time to have cataract surgery or lens surgery, because these lenses are so great. And when you've reached a point where it's like nitpicking type factors where the surgeon's like, well, I kind of like it for this tiny small reason, then that's a great position to be in as a patient, because it's going to go well.
Couldn't agree more. Yeah. Well, it's been a good discussion. I love talking about cataract surgery, multifocal lenses. It's awesome. Episode 10, man. Can you believe we made it?
Double digits.
We're going to start having guests. Yeah. This is our promise.
Yes. Yeah.
To both of our moms, our only listeners.
Yeah.
And all of we had somebody listen from Uzbekistan last week. So just know that we're worldwide.
It's funny because my mom did call me the other day and she told me that her optometrist couldn't refract her to 20/20 anymore.
Uh-huh.
And I was like, it's that darn lens. You got to come see me.
I thought you were going to say your mom was traveling to Uzbekistan and listened to our podcast.
Oh, nice. Yeah, she was.
She called you and she was the listener. Yeah. Well, thanks everybody for listening. The Eye Surgeons, episode 10.
Yeah, I love it. And we'll have so many different topics to talk about. So if anyone actually messages in, it'd be cool. We could talk about whatever they ask.
Absolutely. I'm thinking, and feel free, send your questions in. I'm thinking we have some other ophthalmologists, optometrists, and then switch over to, I think I have some patients that have expressed interest in like talking about their experience and coming on.
Yeah, that would be fantastic.
That'd be cool. Yeah.
Welcome to the Eye Surgeons. I'm Sud Koushik. I'm a refractive surgeon in the Bay Area doing the comprehensive modern vision correction. So EVO ICL, LASIK, PRK, SMILE, custom lens replacement, and refractive cataract surgery.
And I'm Sam Barry, and I'm in Central Illinois. I do the same thing as Dr. Koushik, refractive cataract surgery, LASIK, PRK, EVO ICL, a refractive lens exchange. And we talk about those topics here on this podcast, The Eye Surgeons.
Thanks for tuning in.